Hi everyone, and welcome to our Meet the Expert with Professor Carolyn Sue. It's lovely to have everyone here today, and exceptionally lucky for us to have Professor Sue with us. Just to start, I wanted to introduce myself. I'm Tony Cadden, General Manager at Mito Foundation. I have the privilege of leading our support services team and supporting the organisation in our strategy. And I came to the foundation from a position of lived experience caring for my second daughter, Alana, who had Mito. It's lovely to work with our amazing advisors, team, and community. I'd like to acknowledge the traditional owners of the land that I'm joining from, which is the Gadigal people of the Eora Nation. And I pay respects to elders past and present. I'd like to acknowledge the traditional owners of the various lands on which you are all joining from, and any Aboriginal and Torres Strait Islander people participating in this event today. I'd also like to take a moment to acknowledge everyone that's joining with lived experience, people that have lived with and are living with the experience of Mito, and those who love and care for them. Each person's journey is unique, and we respect and value your generous contributions, which assist us to continually shape the work we do for the Mito community. I particularly love this little slide because it has so many wonderful faces of people we know and work with every day, including my daughter Alana, who Laura, who's also on this call supporting us today, has kindly put almost front and centre. So having the right people in your care team is really important for your overall health and well-being, particularly with conditions like Mito. And that team provides invaluable support when you need it and any challenges you might face. So you might need to see a range of different people and a range of different specialists. Having someone ideally coordinate that care for you is really important. And that could be a metabolic specialist, a neurologist, a paediatrician, or your general practitioner, or even someone else. So when we talk about a Mito specialist, we talk about doctors who diagnose and treat mitochondrial disease, and they specialise in Mito to manage your symptoms, improve your quality of life, and often collaborate with other health professionals to provide that care. So we're going to introduce Carolyn very shortly, and she's going to talk about her clinics and her care network. And if you've got any questions about how to find a healthcare professional, please reach out to us. We have a number of resources, and these will go into the chat that might help you get started on that, and you can reach out to us with any questions. So today's Meet the Expert is Professor Carolyn Sue. Professor Sue is a clinician scientist and a renowned expert in mitochondrial disease. She's currently the Kinghorn Chair, Neurodegeneration at Neura, and Neura is at the forefront of neuroscience and is an independent, not-for-profit medical research institute dedicated to improving the lives of people living with brain and nervous system conditions. Previously, Professor Sue was the head of the Department of Neurogenetics and Neurology at Northern Sydney Local Health District. This was while also leading the Royal North Shore Hospital's Clinic for Mitochondrial Disease, the largest mitochondrial disease clinic in Australia. She is the past executive director of the Colling Institute, where she positioned the institute as a centre of world-leading translational research excellence. Professor Sue is the founding director of Mito Foundation, has previously been chair of Mito Foundation Scientific and Medical Advisory Panel, and has been involved in much of our work over the years. She was instrumental in the development of the patient care standards, which guide clinical care for Mito in Australia, which she'll talk about shortly, and has also been instrumental in the creation of the Mito Medical Network. In 2019, Professor Sue was awarded a Member of Order of Australia, AM. It was for her significant work in medicine, especially on mitochondrial disease. So I'm very pleased to welcome you, Carolyn, to today, and we really value your time and your expertise.
Well, thanks very much, Tony. Let me say thank you to the Motto Foundation for inviting me to be at this Meet the Expert session. Delighted to share with you and your audience and all of those who've been in touch with Mito in this webinar, some of the thoughts and the advances that we've had. You know, we've had, I wanted to just start and say that we've had an enormous advantage over the last 3 decades, which is how long I've been involved with mitochondrial disease in the advancements of the field. So this is where I work. I've now, as you said, moved the mitochondrial clinic to Randwick, where we've established the Mitochondrial Disease Centre. And very lucky to take a team of neurologists and scientists with me so that we can concentrate on trying to provide care to patients with mitochondrial disease at that institute. We're situated just at the back of Prince of Wales Hospital, and we have clinics down on the entry level for those of you on the call who have been lucky enough to come over to the clinics. We'd be keen to show everybody some of the services that we are able to provide. And also on the top of this building, we have laboratory services where we can not only facilitate diagnosis, but also undertake research to help patients with mitochondrial disease. Now, over the past 30 years, we've had a lot of advancements over these 30 years. And really, from my point of view, to start 30 years, we actually celebrated the 30th anniversary of our clinics the other day. In a clinician's lifetime, particularly as a neurologist's lifetime, when you can move through improvements in diagnosis, offer treatments, and then also move on to prevention has been a really a rare occurrence, I think, for those people in the medical field, because sometimes advancements do actually take much longer than you know, the time that one has in their own career span. So I'm very, very lucky, I think, to have been involved in this area where we have seen significant improvements in diagnosis and treatment, and also now prevention. So some of the diagnoses, I think you asked me to mention some highlights that I've had. So I'm going to go to one of the first advances that we have, which was during my PhD thesis. And really the task at hand was to try and improve diagnostic methods for patients with mitochondrial disease, because it was a hard to diagnose disease of that disorder. And for many of our patients, they've had troubles trying to get themselves diagnosed. And in some cases, you know, it takes years, and in other cases, decades to actually reach a diagnosis. So my task was actually to concentrate on trying to diagnose mitochondrial disease with hair follicles, of all things. And we were indeed successful at that. Molecular technologies with genetic testing, such as PCR, polymerase chain reaction, ways to actually amplify small amounts of DNA, particularly mitochondrial DNA, to actually identify the genetic mutations that were causative of this disease in patients. And at that time, muscle biopsy was the gold standard. We knew that it wasn't sensitive. We knew it was painful, it was uncomfortable, and not sensitive. And so trying to find and move to genetic diagnosis at the time was relatively new, and using hair follicles particularly new, but particularly relevant for patients with mitochondrial disease. And particularly in Australia, being able to send hair follicles in the mail, you can do it this way now, but in those days, trying to provide access of genetic testing to people all around Australia was possible by this method. And indeed, we did find a lot of patients and could diagnose patients with mitochondrial disease using this method. During my thesis also, we moved on to treatments, and I've got to say one of the happier occasions was to try and understand how hearing loss occurred in patients with mitochondrial disease. And we did a whole bunch of experiments to show that it was due to cochlear involvement in patients with the hearing loss. And this was one of the more common symptoms. So as most people are aware, Australia was really leading the world in cochlear implants. And so we managed to do the first cochlear implant for treatment of mitochondrial disease in the world during that time. So another major advancement. And then finally, one of the real advances, I think, that in our field has been in looking at preventative measures for mitochondrial disease. Now, during my thesis, and again over the years, we've managed to look at different ways to try and prevent symptoms by using things like exercise therapy and other agents such as L-arginine and so forth. But now we have, with great efforts from the whole scientific community and the community at large, headed by the Mito Foundation, we've been able to legalize IVF techniques such as mitochondrial donation, so that they can lead to protection and prevention of mitochondrial disease in affected families. And so with this in mind, we really have taken an advanced approach and developed this model of care where we look at patients with diagnosis. We actually then assess each patient individually to try and customize a treatment plan. And then we start symptomatic treatment and then think about preventative strategies to maintain optimal care in each individual patient affected with mitochondrial disease in our clinic. And this has really been enhanced by telehealth virtual care, which we can proudly say started before COVID, but was certainly facilitated during the real uptake of virtual care by Australia. And now our clinic is able to see patients from every state and every territory without people having to necessarily leave their homes to come into the clinic physically. So I think that's been a real advancement. And then finally, just to mention the research that we're able to do from patients that are affected with mitochondrial disease. This is just one of our most recent papers that was published last month, showing that if patients do manage to come to a tertiary referral centre such as our one at Neura, then it really does provide all and address all of the social needs that patients have. And so there's that sort of level of care, which we're very, very fortunate to have in Australia, can lead to a better perceived level of support for patients as they face their journey with mitochondrial disease. So I might just leave that talk there and move on to your own questions, or open up to any other questions. Thanks, Tony.
Thank you, Carolyn. It's pretty amazing to see how things have evolved over time. And there's a lot of really interesting things coming down the pipeline too. So thank you for sharing. I'll just come back to the care standards, which you were very, very closely involved in. How would you describe how they've changed the way health professionals can support people with mito?
Yeah, thanks, Tony. Well, the care standards, the standard of care standards for mitochondrial disease, and now provide the roadmap for health professionals to provide care for patients with mitochondrial disease. As we say, 30 years ago when I started this, people really didn't understand what mitochondrial disease was, how you could treat it. It was really a time when people were diagnosed and then, you were sent home with a diagnosis, but no real treatment or care provided. And so that was a lesson that I learned very, very early on when I started improving the diagnostic rates for patients with mitochondrial disease. Then lots of patients used to come to the clinic and they go, well, what do we do next? And so trying to develop, treatment plans for each individual patient. So, we spend a lot of time trying to give some thought as to how we can provide optimal care, particularly in Australia, where healthcare is, relatively accessible. But at that stage, even genetic testing wasn't available to everybody. So trying to move on to and develop a roadmap by which patients can access medical care and follow recommendations of so they can have optimal treatment was important to us. It was great to work with many specialists who were involved in mitochondrial disease care, so that we could standardize our approach. And also, I think we even managed to get access to make them publicly accessible. So, I think we paid for open access so that everybody could really get knowledge of that roadmap that patients may need. And I really would encourage patients out there to download it. And I think I've got the website here linked. Do you want to share that? So
yes, we will, definitely. We'll send a link after the event of all the relevant information. Yeah.
So there, so I think that if people just sort of click on that link, then they're able to download those standards of care, and then hopefully convince your healthcare team to be aware of it and be familiar with the treatment options.
Thank you. Carolyn, you mentioned genetic testing just then as well, and late last year, a number of items were added to Medicare, which is aiming to increase access to testing. What do you think the benefits of having a genetic diagnosis in particular for someone who has they might already have a mitodiagnosis that's not genetic? What do you think the benefits of getting a genetic diagnosis are?
Yeah, I mean, it's a really complex question, and because there are so many benefits, I guess, from having a genetic diagnosis, way better than the previous standard, which was on muscle biopsy diagnosis. So the advantage of a genetic diagnosis is that you have a clarity of what you actually have. Yes, and people out there are probably aware that there are many mitochondrial diseases. So it's an umbrella term, and there are hundreds of rare diseases which combined actually make quite a common sort of group of diseases. But each of those diseases, which has a different genetic cause, might vary the approach to your care and treatment. So having a genetic diagnosis really provides clarity for that. It also provides that dignity of actually having a diagnosis. A lot of patients complain to us saying that, nobody really believes them. They, have trouble convincing healthcare professionals that they have a disease at all. But having a precise, clear and documented diagnosis really does help, your healthcare team to understand what you've got. And to really understand what might happen to you, and therefore create a preventative strategy, or at least an optimal care plan that might help you navigate the journey without too many stumbling blocks. It doesn't change the reality, as you know, but it does actually help people navigate. And we say in this day and age, information is power, and that's precisely what is enabled by the genetic diagnosis. The second thing that it really enables is that, it helps treatment. So for specific mitochondrial diseases, in different genetic subgroups, then treatment is available more and more effective in those. And so we are now looking at precision medicine and personalized medicine, where people do get precise treatments for their genetic causes of mitochondrial disease. One example is for Leber cerebral neuropathy, where a gene therapy is now being designed. And so depending on the genetic diagnosis of patients who have, the symptoms that are associated with Leber cerebral neuropathy, then you can have specific treatments. And then, of course, as you plan your families and your future children, having a precise genetic diagnosis will actually inform the reproductive choices that you might have to minimize the risk to future families.
Great, thank you. And if someone here is wanting to get a genetic diagnosis, what pathway should they follow?
Well, I think, you find a doctor who knows about mitochondrial disease would be a good thing. Clearly, at our clinic, we're able to do this, and we have proposed to the federal government in Australia to provide genetic testing to patients in Australia who are suspected to have mitochondrial disease. So now, through our research with our group and funded by New South Wales government, we were able to demonstrate that whole genome sequencing is an effective method by which you can get diagnosed with your mitochondrial disease. So a single blood test usually will be able to provide a diagnosis in the majority of patients suspected of having mitochondrial disease. And, there's a few caveats with this. This is just why it's good to seek advice from a mitochondrial disease specialist. And as I said, we see patients in our clinic every week for this diagnosis. We go through the process of evaluating what the likelihood of having mitochondrial disease might be. If it's appropriate, we'll send off a genetic test in consultation with the family and the patient themselves, and make sure that they're counselled in the appropriate way. We send our genetic tests off to the laboratory. For us, it's in Randwick, where we have expertise, local expertise that will actually help us do that diagnostic test so that we can provide the care for our patients.
Right. And one of the questions that actually came through a couple of times was people that might have been tested some time ago, but didn't get a definitive diagnosis at that time. What would you suggest to them about getting retested, or any other pathway they could follow?
Yeah, look, that's a great question. I think they should seek testing again if that's what they feel. Obviously, you need to be evaluated by your clinician. Patients who have been suspected of having mitochondrial disease at our clinic, will undergo a clinical evaluation again. I think that's key because, the knowledge that we have, the growing knowledge that we have about the clinical presentations, the symptoms, the likelihood of diseases as genetic diseases are discovered is really important. There's usually a lag in the literature and in the medical field sometimes to actually have that knowledge taken up. So having a clinician that is really on top of the latest developments, genetic discoveries is helpful, or at least someone who's going to look it up, and then also make sure that it's appropriate, because we need to make sure that any test that is ordered is appropriate for that particular patient. And then, the technologies are amazing these days. I mean, I was talking about hair follicles where we did genetic testing in very, very small and limited parts of the whole genome, the mitochondrial genome in that case. But now technology is such that you can sequence the entire lot of DNA in patients. So that includes both genomes. So you can simultaneously sequence the mitochondrial genome as well as the nuclear genome. It's a huge amount of data, and per person, it's about 4 laptop computers worth of information for any one single person. So you need huge computing power to be able to analyze it, bioinformatic expertise. And I was really lucky to work with a whole bunch of people who had great bioinformatic expertise and who helped us develop this diagnostic pathway so that we could get it into clinical service. Unfortunately, our MADSAC application, which is the process by which you get Medicare funding for this sort of process, was successful. And so now I'm very proud to say that through combined efforts, particularly led by our group, we were able to allow access to genetic testing to all Australians suspected of having mitochondrial disease. So, I think with that level of technology, so hopefully people, out there who have entertained the diagnosis of mitochondrial disease will be able to reevaluate this through a Medicare-funded model.
Absolutely. That was certainly something we were very pleased to see happen, and we encourage anyone who's interested to find out more about that.
Yeah, and thank the government. That's what I say. We hardly ever do.
But somebody has to do the work behind the scenes to get their attention. So yeah, thank you for your role in that. That was really important. So shifting a little bit, it was still diagnosis related, but we've had questions about, sometimes there are, some forms of mito, it might run through a family, and some individuals may have a diagnosis and others don't. And the question specifically was around, as people are getting older, maybe into their 60s and 70s, and they might be getting what could be mito-related symptoms, but they're not sure. What's your advice to them? You know, is it worth pursuing a genetic diagnosis, or do you have any other advice?
Yeah, well, that's a loaded question because I'm biased. Remember, I'm a clinician. But look, I think look, in the beginning, mitochondrial disease was thought to be a terminal illness that affected children. But during my thesis, at least, and certainly, you know, in the decades after that, it's been very clear that the majority of patients with mitochondrial disease are actually in adult life. And we have a whole spectrum of disease, and unfortunately, mitochondrial disease covers the whole lifespan. You have, you know, obviously the severe and, you know, tragic cases that where mitochondrial disease presents in young childhood, and of course that's always, you know, very very sad when that happens. But mitochondrial disease, being a genetic disease, is a disorder that can come on in every decade of a human's life. And so if there is mitochondrial disease in the family, then, you know, family members are not actually necessarily going to find out what or when their disease might, or that genetic mutation might actually express itself. And so late disease, you know, in 60s, 70s, 80s, you know, those cases do occur. And so I always think that patients who've got mitochondrial disease deserve the treatment that they deserve the best treatment they should have. And so seeking a diagnosis and seeking appropriate care, regardless of your age, is something that every individual should sort of look for. So I'm not an ageist. I think, you know, everybody who has mitochondrial disease should get the best care and best treatment that they can.
Exactly, and that's the health system is set up for that too. So, yeah, thank you. I think another vote for genetic testing there, just generally.
Yes, no, it's not. You're not confined to any one age group. I think I think information is power, as we just said, and having an accurate diagnosis and understanding. And I'm amazed at a lot of patients who are very courageous and very, very brave. You know, often patients, even though that, you know, they don't perceive a real you know, benefit for themselves from getting a genetic diagnosis. Often, particularly parents, you know, they'll often volunteer themselves to have genetic diagnosis so that they can help their children, spare the child having a genetic diagnosis or the testing for it. That's one scenario that often occurs. But also, I think with that extra information, that of older family members having a genetic disease, although it doesn't change the situation at all. I think, you know, some people are concerned that they, you know, they'll feel guilty that they might have a genetic disease. I think that, you know, days are gone about that being really the norm. I think finding out that genetic diagnosis in the family will help not only that individual, but also the family itself.
Yeah, we've certainly heard from time to time some questions around the need or value of having a genetic diagnosis if there has been a diagnosis already, and we certainly support that. And it was nice to see yesterday it was announced that genetic results will not be considered or not be used to discriminate for insurance. So that's and that has previously been raised as a concern from people. If they get a confirmation of something, what's the risks of having that information? So that was really reassuring to see that change.
Absolutely. And I think, you know, society is now catching up with the fact that, you know, information is really important. Health information is very important to an individual's care. And there should not be any barriers to trying to optimize that.
So we've got a few more questions to work through, and then if we're going pretty well for time, so we'll then probably open up. Well, I think we'll have time to. So if you do have questions, please use the Q&A, and Laura's working in the background to make sure they get to me. We have had one that's come through that is, again, related to a genetic diagnosis. So I'll ask it now. Is it common to have the type of mito change following a genetic diagnosis? The example here is from CPO to KSS.
Okay, so so I guess it really depends on your concept of you know, how mitochondrial disease occurs. As you know, the genetic mutations that you have, or the genetic variants that any individual has, you know, they're basically dished out at conception, and that's what how you're made up is how you're made up, and that's the blueprint to how your body works. How it actually expresses the consequences of that genetic change is a different story. And we know that patients with mitochondrial disease have different ways of expressing the disorder. In fact, my thesis was based on this. It was called, it was entitled Diversity of Phenotypic Expression for the 3-2-4-3 mutation, which basically means in English, you know, there's many different ways that you can present. And then that's not only just in what type of symptoms you have in the body, it's also across the lifespan. So, you know, members of people who actually contributed to my studies when I was doing my thesis all had a common variant in the mitochondrial genome, but their clinical presentations were very, very variable, which was characteristic of one of the mitochondrial disease. You know, we learned many different lessons. I spent hours and hours speaking to patients with this mutation so that I could learn as much as I could about their disease. And they were very, very generous, by the way, in spending the time and you know, explaining to me what they were experiencing. And we knew then that some patients did present in young childhood, but many did present later in adulthood. And then there were different sort of ways and time courses of the illnesses. So I always like to quote about the woman who I met when she was 93, who became symptomatic from her mitochondrial disease in her late 40s. So she'd had about almost 50 years of illness. Now she lived for that 50 years quite well. She didn't, you know, she recovered from her mitochondrial disease symptoms at the age of 40. And gradually had increasing hearing loss. So she was fairly you know, hearing impaired by the time I met her. But she was walking, and you know, the stroke-like episode that she'd had in her 40s, she'd actually recovered from quite well. So that was very encouraging, I thought, in terms of you know, how I thought about you know, surviving the disease, trying to treat the disease, and then learning from people who are actually able to recover from the disease. So we've spent a lot of time trying to look at how that sort of works. And so in that sense, people should be aware that mitochondrial disease can present really at any stage. But you can, I think, make some lifestyle modifications, for example, and approaches to minimize or at least try and delay onset of particular symptoms. And we work very hard in the clinic to educate patients about that, how they should be thinking about their disease, how they should be monitoring or self-monitoring their disease, working with their healthcare team to you know, do investigations to try and prevent expression of their illness so they can have the best way and best quality of life that they can.
And we've heard you talk about the role of nutrition and exercise, particularly. How has that been incorporated into your clinic?
Yeah, absolutely. I mean, well, luckily we have, you know, exercise programs. We're now starting to tailor those exercise programs. We have a physiotherapist in our team now who is looking into this. And we also look at dietary impacts. And we provide advice about nutrition, how one should access and maintain healthy function in the body, which becomes a very, very important part of your healthcare plan. And for those who always come to our clinic, you know, we always talk about, you know, the concept of having, you know, your car, which is your body, which has only half a tank of petrol or, you know, a limited amount of petrol. The energy supply is limited in mitochondrial disease, and trying to maintain, you know, maximum efficiency out of your body, and how to get the most out of the energy that it's supplied. because of the limitations of the mitochondrial disease itself. So we try and educate people about that. We try and address those health issues so that we can optimize someone's function and hopefully improve their quality of life, and improve their journey as they have to travel with mitochondrial disease.
Thank you. We had another question around some of our community have a diagnosis, but they don't yet have symptoms. What's your guidance to those individuals? And it might be related to what you were just talking about in terms of what advice generally would you give to those people about seeing a healthcare professional and preventative or supportive activities?
Yeah, okay. So just for clarification, is the question people who don't have symptoms, what they should do?
Yes.
Usually, patients who come to the clinic usually have symptoms.
Yes.
To clarify. And so it's a rare occasion when people don't have mitochondrial disease that come to the clinic, or don't have any symptoms that come to the clinic. But if they happen to be related to somebody who's coming to the clinic, I can see that might occur. So look, I think there's a couple of points. First of all, we in our clinic, we like to understand what's happening to somebody's own body, their own physiology, particularly if they have or are at risk of having mitochondrial disease. So that's the first thing. And what our approach has always been to try and not only understand the overall physiology of that individual, but also to try and detect illness or symptoms. No, sorry, I should say try and detect evidence of disease before that patient has symptoms, should they have been identified as having mitochondrial disease or been carrying a genetic diagnosis with them through cascade testing or whatever. And so whilst it's an unusual situation where people might be asymptomatic coming to the clinic, we're certainly happy to assess them. And we do that clinically first. If we feel that investigations that might be needed to detect subclinical disease or disease that before anyone notices it, then we'll do that. A best example is, for example, insulin resistance, which is a prelude to diabetes. So just like pregnant women are often given an oral glucose tolerance test, we'll also consider that in patients who might have or be suspected of having mitochondrial disease. We'll also look for evidence of insulin resistance, which is an additional test to the standard oral glucose tolerance test. And if we find insulin resistance, we'll advise people on dietary intake and exercise therapy, which might delay the onset of diabetes, for example, for someone who's at risk of that. So it's the same sort of approach that one might have with gestational diabetes, but obviously it's a higher risk in patients with mitochondrial disease or people who are from the families of people who have mitochondrial disease.
Thank you. You talked about earlier, you mentioned around the counselling that someone might get alongside a diagnosis. We hear that that's not always the experience of people at that time. It's not necessarily a consistent experience of having access to a genetic counsellor. What do you think the importance of that is, and what would you recommend to someone who may not have had it?
Yeah, I mean, optimal genetic counselling is important for people who are considering genetic testing in mitochondrial disease. Again, when finding genetic counselors is sometimes a challenge. At our clinic, we're able to provide the genetic counselling, and we're comfortable, seeing patients all across Australia. So if people are having trouble accessing it, then, feel free to be referred to our clinic. We have a whole team of people that are able to provide that service. There's a triaging process as is appropriate. But for those people who are unable to find appropriate services, then, people are welcome to come to our clinic. But, we are working very, very hard to try and train people all around the country so that you can see someone locally, because the face-to-face experience is often, better received. than that by telehealth. While anybody's, we're a public clinic in that sense. So you do need a referral, but there's no barriers for anybody in Australia coming to our clinic. But there is a process to follow. But we'd also equally be comfortable supporting people who are seeing their local teams to have that sort of level of counselling.
Yeah, thank you. We have seen an increase, I think, in the number of genetic counsellors coming through the education system and into healthcare. So we're optimistic that the issue that we hear around access to them will hopefully improve over time.
Yeah. No, I think, and that's important. I think, genetic counsellors also, I've been involved in the teaching of genetic counsellors in the genetic counsellor schools. And we worked with the head of the teaching unit at a couple of universities to do that. So hopefully this will be a skill that will be more available. But also remember that, doctors and clinicians who are familiar with mitochondrial disease and genetic testing can provide that level of support as well.
Great, thank you. And so in the instance that someone didn't get genetic counselling, perhaps at the time of diagnosis, do you think it's valuable to still seek it at whatever point they're at now?
Well, I mean, I think understanding about your disease and understanding the meaning of having a genetic diagnosis is certainly important and vital to your optimal care. So yes, I think trying to get expert care is something that every Australian deserves, whether they have mitochondrial disease or not. But particularly those people with mitochondrial disease, because it's a rare disease, and the expertise is not always prevalent in local areas. I think it's really important to get the right care that you need. And as a healthcare professional, I make no apologies for just promoting healthcare. And a big part of that is optimal care and also preventative care. So those are really important aspects to a person's health. Because I as a doctor like to have healthy patients rather than sick patients. We've been trained to look after sick patients, but one of our goals is to keep everybody as healthy as possible.
Thank you. I had a question around myoclonus as a symptom. Can you maybe describe a little bit about what it is, and is it linked to developing seizures?
Yeah, that was a good question. So myoclonus is a medical term for rapid sort of jerky movements of the hands or any part of the body. And it's a clinical manifestation of some patients with mitochondrial disease. It doesn't lead to seizures. It was an interesting sort of interpretation. And essentially, myoclonus indicates that there is a sensitivity or a hyper excitability of the brain tissue that's controlling that part of a movement. And so it really reflects a disease process that is going on in the brain, which leads to this spontaneous electrical activity setting off a sort of abnormal movement. I can actually control the movement here and simulate it, but in fact, patients with myoclonus have that happen without them controlling that.
Yeah.
So that's a manifestation of a neurological problem. And so is epilepsy or seizures. So the way that you tie it in is that, both of them can be manifestations of involvement in the brain or in the spinal cord, to be honest. That can occur rarely, but they are neurological manifestations of a process where mitochondrial disease might be affecting. And so they are part of a spectrum. You can have both coexisting. You can have them isolated from each other. You can have, in other words, one without the other. And they're not really related except for that general background of having involvement of the neurological system.
Thank you very much. That are the questions I believe that we've received. Just a call out. We've got a couple of minutes if anybody wants to submit a question. I know Laura's managing them in the background. I'm hearing, I'll just chat a little bit while we wait and see if there's more questions. Oh, here's one. Are there any treatments for complex 1 deficiency?
Well, yes, there are, but I kind of, complex 1 deficiency is a bit of a broad term. The mitochondrial diseases that have complex 1 deficiency include a number of conditions. I'll mention a couple. First of all, Leber's hereditary optic neuropathy. Often the mutations in genes that affect complex 1 are affected in Leber's hereditary optic neuropathy. So there are treatments for that. We've mentioned, well, there's pharmacological agents like idobenone, and there's also now gene therapies that are being developed, and other treatments that are specific for Leber's hereditary optic neuropathy. The 3T43 mutation that we mentioned, or any other mitochondrial DNA mutation that occurs, which has the brunt of the effects on complex 1, can be associated with complex 1 deficiency. But complex 1 deficiency is really a biochemical term. And the way that it works is that a lot of the mitochondrial encoded proteins, a lot of the respiratory chain proteins in complex 1 are encoded by mitochondrial DNA. And so if you have a mutation in mitochondrial DNA, you might have an impact, or the greatest impact, on complex 1. Complex 1 also, by the way, for those who have heard about coenzyme Q10, so coenzyme, it's responsible for sort of shuttling coenzyme Q10 across the respiratory chain. So sometimes people with complex 1 deficiency might benefit from having coenzyme Q10 in their treatment plan. Does that answer the question? I hope so.
Yes, so thank you. I'm just pausing if there's any questions that are coming through. All right. There's lots of talk about different diets like keto, Mediterranean, etc. Should we contact, how do we get guidance on what is best individually?
That's a really good question. I think the Mito Foundation should support a project on nutrition, because it's something, we work with endocrinologists, we work with dietitians, but to be honest with you, it really has to be tailored to a particular person. So while there might be some general concepts that I can tell you, really, I prefer to tailor a nutritional plan to the individual patient, so that we can actually optimize that to the patient's needs. Some general principles. Obviously, you need to have a nutritional plan that will provide you with a good source of energy supply. Clearly, the mitochondria can't always metabolize and utilize the dietary sources into their energy because of the very defect they have. But trying to avoid insulin resistance by changing your nutritional intake is important. So a low GI diet is important to consider. Those patients with bowel problems, often constipation, gastric dysmotility, is an important part of the care plan. And so trying to accommodate those clinical manifestations are important in your healthcare plan. So there are many different aspects that need to be considered when you are thinking about your nutritional plan, but so vitally important, because that's how we all, as humans, draw our energy supply. The basic building blocks for your energy come from your nutrition and your intake, your dietary intake. And so it's important to make sure that you optimize that. And again, we see patients in our clinic to provide that sort of level of information so that they can, again, optimize their function.
Thank you. Yes, hearing some very strong support for those fundamentals of nutrition and exercise and health overall. So we've got one more question. We are going to have to call it there from the questions perspective. I know I'm pretty sure a few more have come through, so I'm sorry we're not going to get to all of them. But the last one is, what are stroke-like symptoms in MELAS?
Yeah, it's a great question. So stroke-like episodes were, that was a term coined by the Colombian people from, the researchers from Columbia University, where I spent my postdoc. It was in the setting of MELAS syndrome, so mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke-like episodes was the acronym. Not easy to remember, but certainly in this audience might be a little bit more familiar to some people. Stroke-like episodes were described the clinical manifestation of a focal neurological deficit. In other words, a loss of nervous system capability. What that means really is, you might lose the strength in an arm or a leg. You might lose the ability to speak. You might lose the ability to see or see normally. And there are many other different neurological characteristics that can be associated with stroke-like episodes, because the neurological system does a whole bunch of things. The brain does a lot of things. But it's in stroke-like episodes, usually there's a loss of function. And not only that, the whole episode is different to a stroke, where you might lose the function because part of the brain cells lose their oxygen supply and function. They have a clinical program, which is a bit of a warning period which leads up to the time when you lose that neurological function. Really important to recognize in patients, because if you have that prelude to the stroke-like episode, we believe that you can actually minimize or try and even circumvent the event. And what I mean by that is, some people get nauseated, they get headaches, they might become constipated, they might have seizures. If you treat early enough in that warning period, then hopefully you can avoid the focal neurological deficit, which can be difficult to recover from. So important to recognize, and again, clinicians need to go through your symptoms, take a detailed history for those patients that have had focal neurological deficits or have had warning signs to go onto it, so that we can work with you and identify triggers that might be avoided, so that you can again prevent some of these episodes from occurring.
Thank you. MELAS is one of the more common types of mito that we hear about, so I think that's really useful. Thank you for explaining that very well. So just in wrapping up very quickly, Carolyn, we really appreciate your time today and your expertise. You have a wealth of knowledge. Some of those questions you were able to prepare for, but some of them you were not. And as always, you were able to respond very comprehensively and simply, which I think is really important for our audience. It can be sometimes pretty overwhelming to hear a lot of the jargon and medical information. So thank you for doing it as simply as possible. I took out of that, and I hope everyone's taken a little something. You'll actually get a poll to complete as well, and there's other links in the chat, and we'll send out an email as well. But some key takeaways for me were around being proactive with your health, finding knowledgeable healthcare professionals who can work with you to have a tailored approach to your care, focusing in on health, like nutrition and exercise, and then depending on what your circumstance and diagnosis are, it might be more tailored. And it's very exciting to see that the technology is there to not only have access to really comprehensive genetic testing, but hopefully quicker, easier and cheaper. And also then the treatment options that are coming through. So thank you very much, Carolyn. We really appreciate your time today. And thanks for everyone for joining us. It's great to have you.
Thanks, Tony. It's lovely to talk to the community out there.